I'm Jan de Faber, and I'm the current president of the IPOSC, the International Pediatric Ophthalmology and Strabismus Council, and I'm very proud to present to you a webinar together with the JASA, that's the Japanese Association for Strabismus and Amblyopia. The two moderators of today are Miho Sato from Japan and Jason Yam from Hong Kong. So without further ado, we would like to start the webinar as soon as possible because we have 6 excellent presentations. And make sure that if you have questions, you can get the answers by keying in the question and answer knob underneath your screen in the Zoom line, and then we will give an answer either orally or at the if not, then you will get a written answer by the presentation. So Miho and Jason, please go ahead.
Good morning, good afternoon, and good evening. I would like to greet you all, depending on where you are. My name is Miho Sato, a president of Japanese Association for Strabismus and Amblyopia. Thank you very much for inviting JASA to the IPOSC joint webinar today. Before the webinar starts, I would like to introduce a little bit about JASA. Our members are currently 1,551, including 733 ophthalmologists and 815 certified orthoptists. We have annual meeting, but because of the spread of COVID-19, it has been very difficult to organize meetings in person. In 2020, the meeting was held on-demand broadcasting. The meeting had over 2,000 of attendees. In 2021, the meeting was held as a live streaming and on-demand broadcasting. Over 1,500 attendees were joined. This year, the meeting was held as a live streaming. Over 1,000 attendees are joined. Next year, we want to have a meeting in person, and the meeting will be held as a joint meeting with the Japanese Association of Pediatric Ophthalmology in Fukushima. History of JASA. JASA was established in 1964 with approximately 280 charter members. The organization of the JASA was preceded by monthly or bi-monthly informal meetings of ophthalmologists. Since 1986, the Congress of JASA has been held once a year. Awards. To commemorate the 3 symposiums of the first Strabismus Symposium organized in 1958 by the Japanese Ophthalmology Society, the Yuge, the Nakagawa, and the Hiroishi Awards for distinguished research papers were established in 1980 to honor the younger members of the JASA. The award winners are honored at the annual scientific meeting. We hosted ISA meeting in 1978 and in 2014 in Kyoto. We welcomed many international strabismologists. They are great memories and great opportunities for JASA members to meet international colleagues and also to expand our knowledge. Activities. Publish the journal and annual report. Establish practice guidelines for pediatric vision screening. Support research on the management of strabismus and amblyopia. conduct research on the effects of digital devices on binocular function, educating ophthalmologists and orthoptists about strabismus, communicate with related international societies, publicize pediatric eye care and adult strabismus management to citizens. These pictures were taken at the last council meeting held on June 16, 2022 as a hybrid style. Our council members consist of 15 ophthalmologists and 4 certified orthoptists. Here are 3 speakers of today: Dr. Tsuranu Yokoyama, Dr. Sachiko Nishina, and Dr. Toshiaki Goseki. They are all very active and leading members of the JASA. They are also very friendly and actively communicating with international friends. Please enjoy today's webinar. We really want to see you in person soon. Thank you.
Dear colleagues and friends, welcome to the webinar. So I'm one of the moderators, Jason Yan from Hong Kong, and with us today, Miho Sato from Japan. And so I will introduce our first speaker. First speaker is John Peter Saunte. Dr. John Peter Saunte is the head of Strabismus team, Department of Ophthalmology from the Risco Pediatric Klostrup University Hospital in Copenhagen, Denmark. Today, he will share with us on the topic of infantile esotropia treatment in 2022.
Thank you. My name is Peiter Saunte. I'm happy to be part of this webinar. Hopefully you can travel to Japan in real time next time. I would like to share some ideas on infantile esotropia treatment nowadays. And I do have a financial disclosure, a patent for screen scope, not relevant to this talk. So let's start with a little exercise. This is a picture showing white letters Japan in front of the blue squint. And if you look close at the screen, go close to the screen and converge, you should be able to have Japan floating in front of squint. If this works, your 3D vision works as well. So the question is, if we strabismologists can repair the brains in infantile esotropia and rescue stereoacuity. Well, infantile esotropia is ET onset before 6 months of age, with limitation of abduction, with a latent nystagmus, inferior oblique overaction, dissociated vertical deviation, and reduced binocular vision, and without neurology disorder. Risk factors for developing infantile esotropia is prematurity, low birth weight, low APGAR score, and maternal smoking. And this child here has a right ET with an inferior oblique overaction, the eyes looking up. A Danish study some years ago showed that if the pregnant woman smokes during pregnancy, each cigarette smoked will increase the risk of having a child with strabismus. So what's the reason why the children develop infantile esotropia? Michael Brodsky has a very interesting theory that we share DNA, but also reflexes with the ancient fish which we originate from. And he discusses that the primitive reflexes which we have the first 6 months of age, if they are not suppressed at age 6 months, then we will develop infantile esotropia, like in DVD. Infantile esotropia is associated with increased risk of amblyopia and loss of stereoacuity, and the reference in this I used here is from 2005, and hopefully the infantile esotropia children nowadays have higher degree of stereoacuity than in this reference. So we do know that this first 6 months of life is crucial. This is a critical period for developing sensory motor development. This is important for development of stereopsis. It's important for the development of stable nystagmus, optokinetic nystagmus. And it's also important for developing smooth pursuit and vergence. So if this is disturbed during the first 6 months of age, these motor functions will not work properly. So what timing of surgery should we choose for infantile esotropia? At what age? There's an interesting development in the last 30 years. In 1994, Ken Wright and co-workers reported 7 patients who had with early surgery, and 5 of 7 had some kind of stereoacuity measurable after the surgery. In 1999, Elveston and his group reported 10 kids, and 4 of them had early surgery. 4 of these had measurable stereoacuity afterwards. To try to understand if early surgery mattered, in Europe there was a big randomized study to look at infantile esotropia, and the early surgery group was operated on 20 months of age. The late surgery group was operated at 49 months of age, and they found a little difference with 30% of the kids in the early surgery group had gross stereoacuity, and the late surgery group, this was even lower. But it seems that if we wanted to make a real difference, there's growing evidence that we need to move earlier on and perform surgery before 8 months of age. If you do this, then a high proportion of the children will have some kind of stereoacuity. This is a report from Wong in 2008. In 2010, a group from Mexico City looked at Botox versus surgery for infantile esotropia in small children. They looked at motor outcomes, and if the angle was below 30 prism diopters, Botox and surgery was equal. But if there was a large angle above 30 prism diopters, surgery should be preferred. So what does the Cochrane study say? Are there any answers there? Well, they looked at this in 2011, and no studies met the selection criteria to answer this question. When I was at the Mayo Clinic in 2014, we tried to look at their group of infantile esotropia kids, and we looked at age of onset, age of surgery, duration of misalignment, stereoacuity, DVD, residual, recurrent ET, consecutive XT, and I share some of the data here on the stereoacuity and DVD. And what we did was to look at children at 5 years of age with prior infantile esotropia. We had 500 children included, but only 45 of them showed up at the 5-year exam. Of these children, 20% of them, the mothers had reported smoking during pregnancy. And the age of surgery in this group was 19 months, ranging from 5 months to 5 years. And most of the children were operated on after 1 year, the 1-year birthday, and 42% of them were operated before 12 months. So what about the stereoacuity? Was this saved? Well, the age of surgery was not before 8 months of age in many of them, so the results are maybe as expected. Only a few children had measurable stereoacuity at 5 years of age, and most of them had very low stereoacuity or no stereoacuity at all. And interestingly, we found no relationship between age of surgery and stereoacuity. But also interesting is that the DVD developed during the first years of life. So children with infantile esotropia has a higher risk of developing DVD. And you see the change here, first 5 years of age. So moving up to the recent years, a very interesting study from a Japanese group by Yagasaki, Yokoyama, and Sukui looked at children with infantile esotropia operated on at different ages. And the very early surgery group before 8 months of age had very high degree of stereoacuity, up to 77% in this group, which is very interesting. So it seems that the golden rule, or the age we need to help the children in before, is around 8 months of age, and then there's a high group of these children who develop stereoacuity. Right, so now we have an idea that we need to help these children at an early age. So you have the child in your office. Here you say to the parents, we want to bring the child to this position with the parallel eyes. And what do they ask? Well, they say, is it safe for my child to have anesthesia? And what do you answer to the parents then? Well, nothing is without risks, and anesthesia has a risk as well. And the Australian group looked at this some years ago and found that approximately 1 out of 10,000 children might have risk of mortality if they undergo anesthesia. But if you convince the parents they should have treatment, our job as strabismus surgeons is to treat the children before the age of 8 months of age, treat before 60 days after onset of strabismus, and realign the eyes to within 10 prism diopters. If it's a small angle, Botox or surgery should be equivalent, but if the angle is above 30 prism diopters, surgery should be preferred. And if you do this, there are a lot of positive outcomes which help the children. They have stereoacuity, better motor status, and less risk of performing further surgery. Thank you, and greetings from Copenhagen.
Next speaker is Dr. Sachiko Nishina. Dr. Nishina is the head of ophthalmology of National Center for Child Health and Development. Her topic is increasing acute acquired comitant esotropia in Japan. Is it related to excess use for digital devices? Dr. Nishina, please.
Good evening, everyone. My name is Sachiko Nishina from the National Center for Child Health and Development, Tokyo, Japan. First, I would like to thank the organizer for giving me this opportunity to present in IPOSC-JASA joint webinar today. My talk is focused on increasing acute acquired comitant esotropia in Japan. As you all know, acute acquired comitant esotropia, AACE, is characterized by an infrequent presentation of esotropia, an acute onset of esotropia with comitance. Sudden diplopia is characteristic in older children and adults, but lack of symptoms in infancy and early childhood accompanied by ocular deviation and voluntary closure of one eye. 3 types were proposed by Burian and Miller 1958 as shown in the slide. In 2015, Book reported 48 pediatric cases of AACE during 13-year period. They are categorized into 7 types as shown on this slide, and one that intracranial disease was present in 6%. Therefore, brain imaging should also be performed for children with AACE. Now, clinical questions for AACE in recent times as follows. Is the frequency of AACE increasing? Which type of AACE is increasing? What age group is increasing? Is there anything unique about the recent patients? What new causes are there? Are social factors surrounding children involved? And are there differences among countries? This talk will inform you about the status of pediatric AACE in Japan. Here I would like to show you the first case of ASCE in a 6-year-old boy in October 2014. Mother noticed his sudden onset of esotropia for the previous year. There were no ocular and systemic symptoms, no history of past diseases, but excess use of the father's smartphone gaming more than 4 hours daily. Examination showed constant esotropia of 35 prism diopters at distant and near without deficit of abductions. Binocular function was not detected. Visual acuity and cephaloparetic refraction were normal. No abnormal findings in anterior segment and fundus in both eyes. No other neurological and systemic abnormalities were found, and brain CT revealed no abnormal findings. I diagnosed this as ASCE, possibly related to excessive use of smartphone. Prohibiting the use of smartphone was ineffective, hence surgery was needed to correct orthophoria and restore stereopsis of 40 seconds with no recurrence. Subsequently, we encountered 7 pediatric strabismus cases possibly related to excessive use of ICT devices and reported at the 13th meeting of the RSA 2018. As shown in the slide, 2 younger children presented ASCE and could not recover without surgery. Other teenagers of worsening or recurrent strabismus responded to restriction of device usage, spectacle correction, and prism therapy. The first report of ASCE related to excessive smartphone use, similar to ours, was reported by Lee in 2016. They reviewed 12 cases within an older age group compared with our ASCE cases. Among their cases, all cases showed an improvement of ET after refraining from smartphone use for 1 month. Then surgery was performed in only 3 cases. In Japan, after our report, increasing reports of ASCE versus excessive use of digital devices were seen, including Ushimaru, Nagayama, Matsunaga, Akatsuka in 2020, and Ezuka in 2021 in Japanese journals as listed. The type of digital devices were smartphone, gaming devices, tablet, and surgery was needed in most cases. Here, I also show you the data of increasing internet usage by elementary school students ages 6 to 12 years based on the surveys on the Internet Use Environment of Use Cabinet Office Government of Japan. Looking at the change over time from 2014 to 2021, the smartphone usage has rapidly increased from 12% to 53%. Similarly, tablet usage has increased from 15% to 49%. In total, surprisingly, Internet usage has risen from 53% to 96% even in this younger age group. Consider the possible pathogenesis. Not all, but only children with a predisposition to strabismus may be the candidates. Excessive use of DD, especially with a viewing distance within 20 cm for smartphones, is a major trigger. It was reported by Hirota and Fujikado in JJO 2018. Excessive efforts of accommodation and convergence continue and out of control with prolonged DD viewing. Disability of fusional divergence and elevated tonus of MR muscles occur, then ET becomes manifest, the onset of ASCE. However, it causes no symptoms in younger children. Therefore, it becomes irreversible and requires surgical treatment. Here, I introduce the survey of JASA and JAPO members nationwide on ASCE in 2018 reported by Imori and Sato. 371 out of 183 member ophthalmologists responded as follows. Question 1. Did you encounter ASCE ages 5 to 35 years in January to December 2018? The answer was yes, diagnosed. was 42.6%, quite a high rate. Question 2. Do you think AACE is related to DD use? And the answer was, yes, I think it's related, was 77.2%, very high. And question 3. Basis for believing they are related. And the answers were, patients said relevant, 30.3%. Parents said relevant, 41%. There was a background of excessive DD use, 91.8%, and improved after limiting the time of DD use, amounted to 30.3%. Now, Japanese multi-center prospective study of ACT in 2019 to 2021 has been performed. 103 facilities nationwide participated. The subject was ACE aged 5 to 35 years of onset within 1 year. Methods were questionnaire and examination of ET at registration 1 month and 3 months later, observational study of 3 months without surgery or Botox. Guidance on limiting the use of DD and request to record daily hours, interval, viewing distance. By December 2021, 200 cases were enrolled. Analysis is in progress, to be reported in the near future. Nowadays, our concerns after COVID-19 is ET related to DD spreading to a younger age group. In this 1-year-old girl, worsening of infantile ET occurred after successful ocular alignment by early surgery, with daily use of her father's smartphone. In this 2-year-old girl, her mother works at home, nursery school was closed due to COVID-19 restriction, then iPad use of 6 to 7 hours triggered AACE. And this 5-year-old boy had enthusiasm for games due to COVID-19 restriction. Smartphone use of 3 hours daily triggered AACE. It is very worrisome that excessive use of DD may cause irreversible stereoscopic deficit during sensitive period under 5 years old. And we should consider that psychological stress from COVID-19 must be an underlying major factor. Thank you for your time and attention.
Thank you for the wonderful lecture by Dr. Nishina. Now we will go to the third speaker. So our third speaker is Professor Chen Zhao, Professor of Ophthalmology, the Chief Doctor of the Division of Pediatric Ophthalmology Strabismus, Vice Chairman of the Department of Ophthalmology, Eye and ENT Hospital, Fudan University School of Medicine in Shanghai of China. So he will share with us another topic on the AACE, the new perspective on acute acquired concomitant esotropia. So Professor Zhao, please.
Hello everyone, my name is Chen Zhao and I'm from Shanghai Eye and ENT Hospital affiliated to Fudan University. I'm very happy to be selected to this session, so first of all, I'd like to thank the organizers for this great opportunity. And today, I'll be talking about new perspectives in acute acquired concomitant esotropia, also called as AACE. AACE is characterized by acute onset of esotropia with diplopia, which usually occurs in older children and adults. And this disease has been previously classified into 3 types, in which the type 3 has become the most frequent type because this type is associated with myopia and excessive near work, such as excessive uses of smartphone. Treatments for AACE are aimed to correct the screen and to restore binocular function. Wearing of prism and injection of biotoxin can be used in the early stage of the disease, but most patients may require an operation eventually. And most surgeons believe that once the deviation is eliminated by surgery, the binocular function should be restored because those patients have established binocular function by the time of the onset of the disease. However, one study showed that only 61% of AAC patients could restore normal stereopsis. Narrowing of binocular fusion range, intraocular suppression can often be observed in AAC patients as demonstrated by another study. And 20% of those patients may complain of recurrence eventually. So there are some questions remain to be understood in this disease. So question 1, what aspects of binocular function could not be restored in AAC patients even after successful surgery? Question 2, what is the mechanism underlying function loss in AAC? Is there any abnormal cortical regulation over the course of this disease? And the last question regarding the surgical plan, is the surgical dosage different between the treatment for AAC patients and other patients with other kinds of esotropia? And in my talk, we will be focusing on the 3 questions. So the first question is, could binocular function be fully restored in AAC patients? Binocular function relies on both combination and rivalry process to eventually form the highest level of binocular vision, that is stereopsis. We then investigate the 3 aspects of binocular function in those AAC patients after surgery. Binocular rivalry is a visual phenomenon in which percept switches back and forth, 1-2 different pictures are presented to each eye. And in this experiment, as you can see here, we did not find significant difference in the process of binocular rivalry between AAC patients after surgery and normal subjects, indicating that the eye dominant status can be restored in AAC patients after surgery. The second experiment we did is a phase combination experiment, and I have no time to go through those details, but this experiment determines the capacity of binocular combination. And in this experiment, we found that AAC patients showed reduced ability of binocular combination than normal by about 20%. And in the third experiment, we also found stereopsis was reduced in AAC patients even after successful surgery by about 50% when compared to control. And this is not a surprise given we already found abnormal binocular combination in AAC patients, as I just mentioned. So now we know not all aspects in binocular function can be restored in AAC patient by surgery. The ability of binocular combination and stereopsis were still reduced in AAC patients compared to control, even when the deviation has been fully corrected. And next question is, what is the mechanism underlying the permanent functional loss in those AAC patients? So regarding to this question, some previous studies from my lab and others have shown that abnormal cortical changes were presented in other kinds of esotropia, both in animal model and in those patients as demonstrated by functional MRI study. So we then want to ask, is there any abnormal cortical regulation in those AACE patients? And this might be underlying the mechanism of functional loss in AACE. So to answer this question, we did 3D resting state functional MRI to compare cortical signal difference between AACE patients and normal subjects. We found that a decreased signal in primary cortex and dorsal parts of cortex, and on the other hand, we found increased signals in bilateral precuneus areas and left fusiform gyrus. We speculate this is compensatory change. Moreover, we found there's a negative correlations in AAC patients between the signals of left inferior frontal gyrus and the age of disease onset. And the signals in right superior temporal gyrus is also negatively correlated with the time of daily neural work. And this finding suggested that the onset of age and the time of daily near work might alter the cortical regulations in AACE patients. We next compare the cortical changes in AACE patients before and after surgery. We found that signals from decreased areas that I just mentioned were partially but not fully restored. And signals of left cuneiform was positively correlated with the improvement of eye deviation. We also found that signals from left fusiform gyrus in AAC patients were still higher than normal subjects even after successful surgery. Okay, now we know over the course of AAC, signals from primary cortex and dorsal parts of cortex are decreased, and signals from bilateral precuneus areas and left fusiform gyrus are increased, and the age of onset and the time of daily near work attribute to normal cortical regulations. And when the surgery is achieved in those patients, some abnormal cortical regulation can be partially recovered, but the signal of left fusiform gyrus in AAC patients were still higher than normal subjects after surgery. Okay, the last question is regarding the surgical plan for AAC patients. Some previous studies have suggested that those AAC patients may need more surgical dose compared with other esotropic patients, but there has been no study regarding unilateral resection procedure in AACE. We then reviewed 47 AAC patients and another 98 patients with other kinds of esotropia. All those patients have received successful surgery. We made a retrospective comparison between the two groups, and we found, indeed, those AAC patients needed significantly greater surgical dose compared with other esotropic patients. So for those patients with deviation smaller than 30 prism diopter, those AAC patients needed 0.38 more millimeter of MR resection and 1.63 more millimeter of LR resection. So in another word, 1 millimeter MR resection plus 1 millimeter LR resection can only correct 7.8 prism diopter of deviation in AAC patients, whereas the same dose can correct 8.6 prism diopter deviation in other esotropic patients. So there indeed a significant difference of surgical dose between the two groups, and this data indicate that augmented surgical amount is required in AC patients to get a better result. So to summarize, our data found that there was residual impairment of binocular vision in those AAC patients even after successful surgery. The abnormal cortical regulation may be one of the mechanisms of irreversible function in AAC patients. The onset age and the type of near work attribute to abnormal cortical regulation. The augmented surgical dose of unilateral resection and resection procedure should be considered in AAC patients for favorable surgical outcomes. And finally, I'd like to stop by acknowledging all my colleagues from my department who had made this study possible. Thank you very much.
Thank you so much to the excellent talk by Professor Chen Zhao. And now we have two talks on AACE, and so we will leave all the question and discussion at the end. So we will have the fourth speaker, Dr. Daniela Cioplean, which is from the Ophthalmology Clinic of Pediatric from Romania. She will share with us on the Convergence assess esotropia, non-surgical and surgical effective treatment. So Daniela, please.
First, I would like to thank to the IPOSC Scientific Committee for this invitation and also to all the colleagues who are part of this webinar. I have no financial interest to disclose. Convergence axis esotropia was defined as esotropia with a larger deviation at near than distance with more than 15 prism diopters, but some authors propose 8PD considering that near diffusion is compromised at deviations larger than 8PD. How do things look in our practice? How we make the diagnosis of convergence axis ET? First, repeated cycloplegic refraction with cyclopentolat 1% or atropine 1% is mandatory. Full cycloplegic refraction correction or maximum tolerated refraction in hyperopic patients should be prescribed and worn, and the deviation measurements should be constant. Near distance incomitance over 15 prism diopters is present with the glasses on these patients. Several methods of treatment have been advocated from bifocal executive or multifocal glasses to different types of surgeries. Because of this large diversity of classifications and treatments, and for simplifying the approach, we propose to divide the patients with convergence axis ET, just for understanding the treatment options, in two big large groups. Non-surgical convergence axis ET, cases with small deviation at distance in which addition corrects the near deviation, and the surgical cases when distance deviation is larger than 8PD or the addition doesn't improve the near deviation. As non-surgical treatment, usually executive bifocal glasses are recommended. Multifocals in children are still controversial, and many strabismologists avoid to prescribe them, despite the fact that some articles report excellent results. With almost 20 years of experience using this type of lenses and cooperating with the opticians, we prefer multifocal glasses in patients with refractive accommodative convergence axis ET who responded to addition. We follow the group of 35 hyperopic patients with multifocals for a period up to 8 years. All of the children had small deviations at distance and over 15 prism diopters at near with the monofocals, while with multifocals, near deviation decreased under 8PD. Fusion at distance and near was present in all patients with the multifocals on. Moreover, the deviation reduction at near with multifocals was approximately 1547 prism diopters. The distance deviation significantly decreased too, probably because of less overall accommodative effort in time. All 35 patients had positive ortho tests at near and distance with the multifocals, and stereopsis at near was present in most of cases with the multifocals on. All 8 of these patients discontinued multifocals in time because of spontaneous reduction of the convergence axis after age 10. This is an example with multifocals and with monofocals on the upper side. Regarding the surgical treatment, several procedures have been proposed for convergence axis ET correction. In my hands, 3 methods work pretty well with good long-term results. Bilateral posterior scleral or pulley fixation, and bilateral medial rectus slanted recession. I didn't try yet the other 3 methods. I would like to present you our results in 3 surgical patient subgroups with a long period of post-surgical follow-up. 22 patients who had bilateral medial rectus posterior pulley fixation, 20 patients who had bilateral medial rectus faden, both with or without additional medial rectus recession, and the third group in which our surgery was bilateral medial rectus slanted recession. The follow-up was between 2 and 8 years. This is schematically how the medial rectus is posteriorly fixated with a 5-0 non-resorbable suture to the sclera, as you can see on the left side, and to the pulley on the right side at 12 to 14 millimeters from the medial rectus anatomical insertion. The surgery efficacy is very tight correlated with the insertion points of the suture, and in both situations, the right place is in the neighborhood of the vertical veins, which makes the surgery difficult. What we found analyzing the 2 subgroups with medial rectus posterior fixation, faden or pulley, is a similar reduction of the distance and near deviation, and a similar near distance incomitance reduction of approximately 12.5 prism diopters using the procedures as I previously described. Going deeper in our analysis, we found also that no consecutive exotropia was found in both surgical subgroups, undercorrection being more likely to happen than overcorrections. In the meantime, the symmetry goes further because in each group, 2 cases needed multifocals after surgery in order to correct the residual convergence excess, a small number of cases requiring botulinum toxin or reoperation. The medial rectus muscle slanted recession is a procedure with recesses in different quantities, the superior and the inferior fibers of the medial rectus muscle. The new insertion will be oblique and not parallel with the anatomical insertion. The superior point of the new insertion will be recessed according to the distance deviation, and the inferior one according to the near deviation in an oblique manner. In summary, as you can see in this graph, the near distance gradient deviation reduction by this surgical procedure was 10.48 Pris diopters, the overall result being good and very good to other 2 surgical procedures with a small residual deviation at distance and near. As general overview, 2 patients needed multifocals because of residual deviation at near. In 1 patient, a new surgery was necessary for residual convergence access, which didn't respond to multifocals, and the option was bilateral medial rectus faden. 1 patient had an exoshift at more than 2 years after surgery. 1 case was slightly overcorrected at distance. So, we propose multifocals only in cases with refractive accommodative convergence axis esotropia, in which the distance deviation is under 8 Pris diopters with the monofocals, the patient fuses at distance, he is over 4 years old, and the spherical addition to his monofocal full correction glasses reduces the near deviation under 8 PD. The lenses fitting in the frame is essential. The optical center should be elevated with 3 to 4 millimeters, depending on the child's height. We propose to use bimedial medial rectus posterior fixation as a single procedure. Doesn't matter if to the sclera or to the pulley, when the distance deviation is small and the near deviation is up to 20 Pris diopters. Add unilateral medial rectus recession if the near deviation exceeds 20 Pris diopters. Another indication, in our opinion, is as a combined procedure with bilateral medial rectus recession if the distance deviation is over 30-35 Pris diopters and the near deviation is over 45-50 Pris diopters. The clue is to insert a non-resorbable suture at the vorticose vein level, otherwise it will not be effective. This procedure is available also for previous recessed medials, including slanted recessions. I think we safely can use bilateral slanted medial rectus muscle recession procedure if distance deviation is between 10 to 30 Pris diopters, the near deviation under 40-45 Pris diopters, and the near distance gradient is between 10 to 20 Pris diopters. It is probably advisable to not slant more than 2 millimeters. This is an effective and simple technique. The distance exoshift and or overcorrections are possible, but rare. In conclusion, the term convergence axis esotropia combines several types of esotropia having in common a larger deviation at near than the distance deviation with over 15 Pris diopters, but more precisely over 10 Pris diopters. The optical treatment consisting in multifocal or bifocal glasses addresses mostly to the patients with significant binocularity potential. The surgery is less predictable than in concomitant esotropia, and sometimes different procedures have to be combined for an optimum result, including multifocal glasses after surgery. In about 5 to 10% of cases, reoperation or Botox are necessary for residual or recurrent deviations, especially in very large previous ET or very large previous near distance incomitants. Thank you for your attention and best regards to all my friends all over the world. See you in Cancun.
Thank you, Daniela. Next speaker is Dr. Tsuranu Yokoyama from Japan. He is the Chief of Pediatric Ophthalmology in Osaka City General Hospital. And also he is the Bielszewski Lecturer of ISA 2014. Dr. Tsuranu, please.
Hello everyone. My topic today is the angle of dislocation in highly myopic strabismus. This is the overview of today's talk. Number 1. What is the angle of dislocation? It describes the severity of globe dislocation in esotropia caused by high myopia. Number 2. How is it useful? It is an important marker to distinguish myopic strabismus from other types of esotropia. Number 3. Is it always dependable? No, it has limitations. It sometimes does not reflect the real state of globe dislocation. The angle of dislocation was originally devised to quantitatively evaluate the degree of globe dislocation. Before going into details, I will give you a general idea about globe dislocation in myopic strabismus. This is a three-dimensional reconstruction created from a series of coronal MR images in a patient with convergent strabismus fixus. The globe, extraocular muscles, and optic nerve are shown. The posterior part of the globe dislocates from the muscle cone and fixed between the superior and lateral rectus muscles. This slide explains how to measure the angle of dislocation on a coronal MR image. Small red circles in the slide represent the centers of the superior rectus, globe, and lateral rectus muscle, which are labeled SG and L respectively. Angle SGL facing the superior temporal wall of the orbit is shown with a curved line. This is the angle of dislocation. The angle of dislocation is used to identify highly myopic strabismus. It can also be used to predict the severity of restriction in ocular movements. These images show various degrees of globe dislocation. The leftmost image is taken from a highly myopic patient without strabismus. The globe lies within the muscle cone, and the dislocation angle is only 115 degrees. I'd like to emphasize here that this eye is in the infraadducted position because I intended to use it as a control to study convergent strabismus fixus. The second image is a moderate case of myopic strabismus. The angle is 181 degrees. This patient has restriction in abduction, but can move the eye as far as the midline. The third image is convergent strabismus fixus, the most advanced type of highly myopic strabismus. This eye is typically fixed at an esotropic and hypotropic position. The angle of dislocation is the largest of the three, 247 degrees. So far, so good. However, I have found that relying too much on the angle of dislocation may sometimes lead to the wrong conclusion. Globe dislocation is not always represented properly with the dislocation angle. In the next slide, I'll show you an example. This patient has esotropia of 55 prism diopters and high myopia, but can abduct both eyes beyond the midline. The limitation in supratraction is not prominent. The axial scan on the left shows elongated eyes because of axial high myopia. The coronal scan in the primary position, the right image, Both lateral rectus muscles are shifted below, but no globe dislocation is found. The LR-SR band is displaced supertemporally and partially disrupted. If you have this coronal image only, you cannot tell it from sagging eye syndrome. When eyes are infraducted, the situation changes entirely. Both globes are sticking out of the muscle cone, pushing aside the lateral and superior rectus muscles. The point is that globe dislocation becomes obvious only when the eyes are in the infraducted position. Then, does the dislocation angle increase according to the presence of globe dislocation? The table in this slide lists the dislocation angles calculated from the 3 coronal images recorded in different gaze directions. In the right eye, dislocation angle increases from 132 to 141 degrees with infraadduction, an increase of 9 degrees. In the left eye, from 145 to 155, an increase of 10 degrees. However, the increase of the dislocation angle is too small considering the sudden emergence of a large globe dislocation. A close examination proves that the increase of the dislocation angle can mainly be attributed to the shift of the superior rectus muscles, which are further displaced nasally by the dislocated globe. As shown in the table, their additional displacements are 14 and 13 degrees, which are larger than the increase of the dislocation angle itself. The problem is, however, that all the dislocation angles measured in different gaze directions are large enough to decide the presence of globe dislocation, irrespective of its actual existence. I must admit that they are no longer a dependable marker for the presence of globe dislocation. Now, I'll show you another and more problematic example in the next slide. This is an advanced case of sagging eye syndrome. The patient has esotropia of about 40 prism diopters, both at near and distance. The coronal MRI in primary position shows inferior displacement of the lateral rectus, but infraadduction does not produce any globe dislocation, as in highly myopic strabismus. This is because the eye is spherical and axial length is not elongated in this type of strabismus. Calculated angles of dislocation are 145 in the right eye and 140 in the left. Both values should be large enough to ensure the presence of globe dislocation, which is contrary to the fact. We may need a better indicator for evaluating globe dislocation more correctly. These are my conclusions. The angle of dislocation has been useful for diagnosing esotropia caused by high myopia. In fact, I still use it as a useful tool to find highly myopic strabismus. However, in mild type of highly myopic strabismus, globe dislocation appears only in infraadduction, not in primary position. Besides, the angle of dislocation is always large, even when there is no dislocation. In other words, it does not correctly point at the presence of globe dislocation. Worse, sagging eye syndrome can have a significantly large angle of dislocation, although it has no globe dislocation at all. In short, we need a better indicator for a quantitative analysis of globe dislocation, which is a distinctive characteristic of highly myopic strabismus. Thank you for watching.
Thank you very much, Dr. Yokoyama. The next speaker is Dr. Toshiaki Goseki. He is a professor of Atami Hospital of International University of Health and Welfare. His topic is esotropia with sagging eye syndrome. Dr. Goseki, please.
Hello, good morning, good afternoon, good evening, hello everyone. I'm Toshiaki Goseki from Japan. I would like to talk about esotropia with sagging eye syndrome today. I have no conflicts of interest associated with this presentation. In previous reports, cohort studies have shown an increase in adult onset strabismus after age 60, with a reported incidence of 4%. Additionally, we also reported a similar prevalence of adult onset strabismus at 3.6%. There are two large studies that looked at the cause of diplopia in adult patients. In these studies, 236 patients over 60 years in Japan and 945 patients over 40 years in US were included. Number one cause of diplopia was sagging eye syndrome in both countries, with the prevalence rate of 24% in Japan and 31% in US. Trochlear nerve palsy, which used to be the number one cause of diplopia, was shown to be the second most common cause of diplopia in both studies. Sagging eye syndrome is horizontal and or cyclovertical strabismus caused by age-related orthopedic connective tissue degeneration that was first described in 2009 by Rutter and Dimmer. There are the T2-weighted MRI image in current plan. The left one is of normal person and the right one is of sagging eye syndrome patient. The arrow showed LRSL ligament, which was displaced inferolaterally in sagging eye syndrome, as you can find in the right image. Symmetric sagging of the lateral rectus muscles in both eyes caused divergence insufficiency esotropia, and asymmetric sagging can cause cyclovertical strabismus. However, abnormalities of LRSR band can also be observed in non-strabismus patients. One of the previous studies demonstrated 22 to 26% of abnormalities on LRSR band in 100 non-strabismus patients, and our study shows 41.2% LRSR band abnormalities in patients with optic neuritis over 60 years of age. Thus, sagging eye syndrome cannot be diagnosed by displaced LRSR ligament only. Patients with sagging eye syndrome are recognizable from their external appearance. It is called sagging-like face. Sunken upper eyelid marked with arrow, baggy lower eyelids marked with arrowhead, and aproneurotic ptosis. And the patient often harbor histories of oculoplastic surgeries. Let me introduce a typical case. The case is 73 years old male, started to have double vision since a year ago. The corrected decimal visual acuity was 1.2 in each eye. Superduction were limited in both eyes. He had a sunken upper eyelid and baggy lower eyelid. The deviation was approximately 15 prism diopters at distance. No strabismus was observed at near. Here is a MRI with non-flat suppressed coronal T2 weighted image. Rupture of LRSR band, inferior displacement of lateral rectus muscle, and temporal displacement of the superior part was observed. We performed bilateral medial rectus muscle recession. The target angle was 35 prism diopters. It was double the maximum ESO deviation based on the previous study, which demonstrated the undercorrection when following standard surgical dose table. At post-operative 3 months, the deviation was exfoliar at near and osfoliar at distance. Next, let me introduce our retrospective observation study on the prevalence of sagging eye syndrome in adults with binocular diplopia. We reviewed medical record of 945 new patients over age 40 who presented to the Stein Eye Institute UCLA with binocular diplopia between January 2015 and December 2018. The mean age of patient was 67 years, and there was minimal female predominant in diplopia overall. There were 297 patients with sagging eye syndrome and 648 other diplopia patients. The proportion of sagging eye syndrome in diplopia patients increased with age. The red bars showed the progressive increase in proportion of sagging eye syndrome from about 5% under age 50 to 60% over age 19 years. Patients with diplopia due to sagging eye syndrome were significantly more likely to be female than male. 60% of sagging eye syndrome cases were female. On the other hand, gender was about equally distributed in other cases of diplopia. 65% of sagging eye syndrome cases were cyclovertical strabismus with or without horizontal deviations, and 35% of sagging eye syndrome cases were esotropia at distance more than near. The 104 patients with esotropia at distance more than near due to sagging eye syndrome averaged about 10 prism diopter esotropia at distance, but about 2 prism diopter at near. The 193 patients with cyclovertical deviation averaged about 4 prism diopters hypertropia and 4 prism diopters esotropia at distance, but no significant horizontal strabismus at near. 34% of patients with sagging eye syndrome were treated with prism spectacles, while 60% had strabismus surgery. Esotropia and hypertropia were decreased by strabismus surgery. Surgery resolved the diplopia in all cases. This is my final slide, and there are the take-home messages. Sagging eye syndrome is manifestation of age-related orbital pili degeneration, especially associated with severe elongation of the LRSR band, leading to its ruptures and inferior displacement of lateral rectus muscle and temporal displacement of the superior part of the lateral rectus muscle. Consequently, these cause divergence insufficiency, esotropia, and/or cyclovertical strabismus with small angle. Additionally, sagging-like face, because of degeneration of orbital connective tissue, is important as well. According to the recent studies, more than one-fourth of elderly diplopia patients have sagging eye syndrome, which might have been missed when diagnosing the patient due to small deviation. The patient with sagging eye syndrome might come to your office tomorrow. I hope this presentation helps strabismologists to correctly diagnose patients with sagging eye syndrome. Thank you for your kind attention.
Thank you to our wonderful faculty and the excellent talks. And now we come to the panel discussion. Can we invite all our panel to switch on their video camera so that we can have some discussion, some to follow up the previous questions, and some to have an active ongoing discussion for elaboration of some of the points. Maybe Miho, do you want to start the questions?
Yes, Dr. Nishina had a question and she's going to answer on live. The question is from Dr. Mohammed Jafar. If the clinical exam shows no incomitance, papilledema, etc., and patient has no neurological signs or symptoms, do you have to perform imaging, CT or MRI in this late onset esotropia? Dr. Nishina, please.
Thank you. Thank you for asking important points of controversial. If the family agreed, I always perform CT or MRI imaging for those patients without any other symptoms, because I met 2 patients of brain tumor without any other sign. And maybe the incidence is about 1 in 10,000 times, I think. Thank you.
Can we also ask Chen to also elaborate your point whether you meet some of these patients, would you go for imaging?
I'm not doing imaging for all those patients. I'm totally agree with Dr. Sato.
So how about the other panels? In case you have acute onset of esotropia in children without any concomitant and no papillary edema, no other so-called red flag sign, will you go for imaging for these kids, or you just observe it? John, what's your view?
Yes, I think with the increasing availability in MRI scans now, it's the level or the demand from the patient, from the parents, it seems that the MRI scan is often performed, even though we can't really, for medical reasons, argue that it's necessary to do this. So if the patient comes in with with the parents telling us we want the MRI scan, our child has a squint, it's very difficult to avoid performing the MRI scan, I think, even though we can't really say that the data supports this.
Yeah, I think it depends on the patient age and how acute is acute. I mean, the acute onset is not always one day or a few days before, but sometimes it's intermittently, or sometimes just did not notice the onset. So it depends on the age, older age, and who had acutely noticed, but they had esotropia intermittently or long term. It may not always needed or emergency. But for the young patients and really acute onset within a few days, definitely need.
Thank you. So may I ask another question for the AACE surgical dosage? Chen, you have presented that you usually do a larger dosage. And how large you usually aim for this surgical dosage for this patient?
Yeah, that's a very important question. I think I would do 1 millimeter more IMR resection plus 1 millimeter more IR resection for those patients.
Do you worry about any overcorrection for these children, or you usually do not see any overcorrection?
Well, I do not, because for most of the patients, I mean, for the diagnosis for those patients of AAC, I do not diagnose for patients under age of 9 years old. For those patients, I do not diagnose for AAC because for those patients, I think they have fully established binocular function, and those patients develop sudden onset of esotropia. I probably will diagnose as AAC. So I mean, for those patients, in general I would do surgery under mic monitor anesthesia, so I can monitor their eye position, when I do this resection and resection. So I do not worry about overcorrection. And another point, I think for those patients, sometimes I think in many cases we cannot really do the very accurate measurements. That means you cannot get really real largest number for those esotropia. See, you get like a 30 present diopter of esotropia from patient, and this patient maybe have 35 or even 40 present diopter of esotropia. So that's why I often target the angle a little bit more than normal. So I don't in general I don't worry about overcorrection. That's my personal opinion.
Thank you. So one more question on AAC for both Chen and also Dr. Nishina. Do you do Botox for these cases? What do you think about the use of Botox?
Yeah, Dr. Nishida, you go first.
I worked at Children's Hospital, and in Japan, Botox under 12 age old is prohibited by governments. I have no experience of using Botox for any esotropia in Japanese patient of a younger patient. So please let me know the information.
Me neither. I don't use Botox injection, in general, because I think that's, first of all, it's not quantitative, and second of all, it's reversible. So why bother to inject by toxin? I just wait for a little bit. I would prescribe present for in early stage to see how that works out with those patients, and if that doesn't work out with the patient, I would do surgery. I would not. I mean, to my point, I would not do Botox injection. Although I put that in my slide because some other surgeons do that, but I would not do this.
Thank you. So one more question to Dr. Nishida. How do you advise the patient to refrain from the digital device, and how long for the use of digital device in case you are seeing a lot of increased AAC because of the?
Yes, maybe some patients affect 3 or 4 hours per day. However, a younger patient under 2 years old, maybe the 30 minutes may be harmful for very premature brain system. So I alarm for parents of the children are not using digital devices under 2 years old. My experience.
Thank you. So maybe we move on to the next topic. So may we ask about Dr. Yokoyama?
Yep.
Dr. Yokoyama. So we all learn a lot from your presentation, especially the Yokoyama procedure. So how do you decide to do one eye or both eye for the patient with high myopia esotropia?
Thank you. If the patient has bilateral globe dislocation, I would do bilateral surgery, union suture of the superior and lateral rectus muscles. I do unilateral surgery only in unilateral cases, because in bilateral cases, if you do unilateral surgery, and vertical deviation that did not occur in pre-surgically appears after the surgery. So I do not do unilateral surgery on bilateral cases. Okay.
Thank you. So do you have any dosage in mind, or do you do adjustable for the medial rectus, all the cases? Do you worry about any overcorrection or not successful operation?
In previous report, I suggested medial rectus recession, but to be honest, I think medial rectus recession is not effective on highly myopic strabismus. So I do only union surgery.
Yokoyama, here is Dr. De Faber from the Netherlands. Would you do surgery on a heavy eye phenomenon only on the clinical appearance without an MRI, if the clinical picture is clear?
Yes, I have never done union surgery without MRI.
Okay. Thank you. That's a clear answer.
Yeah.
Thank you. May I ask? Yes, Dr. Goseki.
Yes. So as I have also the opinion of the Dr. Yokoyama's presentation. So I think the cases you have shown as sagging eye syndrome might be outside the definition of sagging eye syndrome. Dr. Dimmer defined sagging eye syndrome is Horia at near. But however, so I have reported more severe cases, same as your case in Japan. In other words, so I believe that when some other case is added to sagging eye syndrome, it became a more severe form of esotropia. And I think the one of them is high myopia. So what do you think about it?
I agree with Dr. Goseki. Thank you. And in my presentation, I showed an advanced case of
advanced case.
advanced case of
so you mentioned
sagging eye
about
syndrome.
the advanced.
Yeah.
Okay, I agree with your presentation.
Thank you. So may I ask question to Daniela? You have presented a wonderful lecture, and it also aroused a lot of interest, especially on the use of multifocal spectacles. Do you want to elaborate a bit more? Seems that other people also have some use bifocal, some use multifocal or progressive. Do you have any opinion on that?
Yes, thank you for the question. I have a lot of experience in using this kind of progressive lens. Multifocals, in my terms, means multifocal lenses. Multifocals and progressive are the same, because I had a question about trifocals and bifocals and so on. So those glasses, those lenses, which have on the upper side the dioptry for distance, and on the lower side an addition, which can be plus 2.5 or 3 dioptries, are glasses which can be very, very easy used by children, because they adapt. They have a very, very high plasticity and power of adaptation. And I think this passing from the distance dioptry to the near dioptry is very smooth. So they don't need to accommodate in the intermediate distance. So if the lenses are very well fitted in the frame, I think it can be a successful method of treatment because they restore binocularity. And as you saw in my presentation, all those children had a very good stereopsis at near. That means that is useful, but it doesn't work if there are not binocular at distance, because I had another question and I want to clarify. So I will indicate those multifocals only in children who have fusion at distance, very small deviations or at all deviation, and in which the near addition brings more binocularity or brings binocularity and the deviation becomes 0 or under 8 prism diopters. So, but it's very important to be connected with the optical department, because I have the chance to work in a private clinic and I have everything around me. So it's very, very easy to control what is happening there, how the things are done. So the process is followed from the prescription up to the glasses manufacturing. So probably I'm very lucky with this. I'm not so sure everywhere is available, and we don't have optometrists, we don't have orthoptists, so we have to do our own everything in my country. So we are in the same time optometrists, orthoptists, ophthalmologists, and we have to know all the process from the beginning to the end.
Yes, Dr. Nishina.
I have a question for you. You said that you don't prescribe multifocal lenses for children under 4 years old. How do you deal with children under 4 years old?
Actually, under 4 years old, usually I follow them. I repeat the cycloplegic refraction because sometimes it's very tricky. There is latent hyperopia, which is not detected at the first cycloplegia measurement. I try to use atropine if I am not pleased about cyclopentalate, especially in children with very dark eyes. And in most cases, I think it's a fake convergence excess esotropia. But in the real ones, I wait, I repeat, and usually after 3, maybe 3.5, if it's a real convergence excess esotropia, I prescribe them glasses. Or of course, the surgery can be done, but I would not do it probably at the first option in a child who is very straight at distance. And
thank you, Daniela. I missed to introduce Daniela. In fact, she is the president of the Romanian Society of Pediatric and Strabismus, and also the vice president of ESA. Thank you, Daniela. May I have one question? Oh, John, you want to have a question? Yes.
Thank you. That's a comment for the acute acquired comitant esotropia talks. And regarding the treatment of Botox, we have tried to use Botox the last 4 years in our clinic, and the results we get are equivalent to surgery now. So we, as a first-line treatment, offer Botox for the first option, and we use 5 units of dose of Botox in both medial recti at once in a very short general anesthesia, where the child is held on a mask, and we can just inject both medial recti. So it's like a 5 minutes anesthesia, and it seems that it lasts. And some of the children get ptosis, and if it works very well, the children have a XT, and then after the next weeks they go into a parallel, and they seems to stay ortho. So we usually offer this as a first treatment now.
Oh, bilateral.
Bilateral, yes. 5 units in both medial rectus.
Thank you for your comment. I'm so much teacher. So much for me. So I have another question for John. I'm sorry. How about infantile esotropia? I would like to know the sensory outcome of Botox versus surgery for infantile esotropia patients for your experience.
So your question is the how many children have stereoacuity after Botox?
Is
Yes.
superior in buttocks or surgery?
Yes, I would like to answer that question. And currently we are not able to offer early treatment yet here. And this is a long discussion. We have lack of anesthesia for the small children, and often our anesthesia has to be postponed because other children need it more, cancer treatment in other children. So I can't answer that question yet.
Thank you.
John, may I also ask, for infantile esotropia, in fact, the angle is very large and the baby is very small. Do you have any tips for how much we should usually do for the bilateral MR resection, or how to for a better outcome?
Yeah, it seems that if the angle is more than 30 prism diopters, Botox does not work. That we know that from the Mexico City group, and the Americans usually use bimedial recti recessions for 5 or 6 millimeters, but usually not more than 6.5 millimeters.
Yes, maybe Daniela and then Dr. Goseki.
Yes, I would like to make a comment. What is very interesting in the very small children is that sometimes, or in most of cases, large recession of 6 millimeters can correct much more than you expect. This is very interesting because you have, I don't know, 80 prism diopters, 90 prism diopters of cross-eyes syndrome and so on, and most of them become straight. This is very interesting. It's not very highly correlated in very large deviation with the nomograms. So I think we have to to study more those issues. But in my hands and in my experience, it can correct much more than 40 or 50 prism diopters if it's done at a very early age. Thank you.
Thank you. Thank you. Maybe Dr. Goseki?
Yeah, yes. I have a question about the John. So the very basic question. So I'm not good at the so infantile esotropia therapy. So how do you quantify when APCT is not available to determine a surgical dose? What do you do?
So the APCT, if it's not useful,
APCT is cannot measure. So when children is very small. So okay.
Yes, you usually use the Krimsky method to measure the angle, and measuring at distance might be difficult. So sometimes you only get the Krimsky at near.
Okay, thank you very much.
So may we have one question to Dr. Goseki? So you have presented excellent lecture on second eye syndrome. First, I would like you to, can you highlight with us what's the difference between second eye syndrome and heavy eye syndrome? And the second is, what is a preferred surgical option? You presented you use medial rectus resection, but some may suggest to use a lateral rectus resection. So what do you think?
The first is sagging eye syndrome is the cause of the sagging eye syndrome is aging, and the heavy eye syndrome is the cause is the high myopia. So this is the different cause, but the angle is sometimes the same, and so the second question is the treatment. I prefer the bilateral medial recession because when after that sorry about this. So when the patient is when the patient have the high myopia, so I cannot distinguish heavy eye or sagging eye. So that's why I choose both medial recession at first.
When you, Dr. Goseki, when you say high myopia, does it mean the actual length over 30 or around 27, or are there any indicator for the high myopia, not high, ultra high myopia may exist?
Yeah, so this is a difficult question. So sometimes the patient have a less than 26 millimeters, so have the heavy eye syndrome. So I usually use 26 millimeter. It's yeah. So and also I use the -6 diopter.
How do you think, Dr. Yokoyama? Do you agree with the definition of high myopia? Usually high myopia indicates -6 or, over minus. But when we talk about, you talk about the highly myopic esotropia, it may be, exceeding over 30 millimeter of actual length, and maybe -10 or -12, 14, or something like that. It may be completely different.
Actually, all the patients I have experienced had 27 or larger axial lengths. So I am almost agreed with Dr. Goseki, 26 millimeters. But the point is, when I say highly myopic strabismus, it has globe dislocation out of the muscle cone. So
Yeah.
that is the point.
Yeah, I totally agree with Dr. Yokoyama. The position of the eye is the most important. So that's why. So we take a MRI before the surgery.
Thank you very much.
Dr. Goseki, one more point. In your presentation, Jan de Faber from the Netherlands, in your presentation, you showed that more women had sagging eyes than men. Is that because women simply get older and have more chance of getting this problem, or is it really a gender difference?
Yeah, thank you for asking. So the Dr. Dima and I and thinking about the collagen. So the old lady have the less collagen than the old man. So that's why. So the collagen is important. We thinking about it.
Thank you. Thank you so much. So if we continue the discussion, it will be till a few more hours. So we have to to finish this webinar. But before that, we would like to invite Seti to help us to have a closing remark and announce our next webinar.
It's my pleasure to announce the next webinar. It will be organized for IPOSC with Chinese Association of Pediatric Ophthalmology and Strabismus. It will take part in October 29, and the host will be American Association of Ophthalmology. And so there will be, the topic of it will be heartbreaking, very impressive, and very important for all pediatric ophthalmologists, myopia. 6 great topics from 6 great speakers. So please come and we invite you to IPOSC-JASA webinar. Thank you.
So may I ask Miho to say the last few words to end this webinar?
Oh, thank you very much for Japanese Association of Strabismus and Amblyopia to join the IPOSC webinar. Thank you very much, and see you in Cancun or somewhere.
Thank you so much. Bye-bye.
Bye-bye.
Thank you.